Hello, everyone. Like, uh, my name is Ruqayya, and I am an international medical graduate with a special interest in maternal and child healthcare, working as a clinical assistant in OBN. So this presentation is made under guidance of Dr. Salim, and I would like to thank him for giving me this opportunity. Before I start, I would like to just disclose that this presentation is intended for education purposes only. There's no commercial content or support. There's no conflict of interest has been found, and resources are shared at the bottom of each slide or end of the presentation. So we have included nipple pain in our presentation, especially some concepts about nipple vasoconstriction during breastfeeding. So let's review some concepts.
Can I add something here? So this topic came in when we talk a lot about nipple vasospasm. So we thought that we'll go in and clarify some of the questions or concerns or confusion around vasospasm. What is the difference between vasospasm and vasoconstriction, and how should we address that? Please proceed.
Yes. So what we found that vasoconstriction and vasospasm has interchangeably used in the literature, but it has been concluded with a lot of research that actually it's arteriolar vasoconstriction that is causing a brief vasospasm of the nipple. So sore nipple. So we should be able to differentiate between sore nipples and the actual trauma. So how could we do that? Sore nipples are one of the most common complaints by mothers in the immediate postpartum period. So that's why normal sensitivity versus nipple pain due to trauma should be distinguished. How can we do that? So normal sensitivity typically subsides approximately 30 seconds to 1 minute after suckling begins. And it also diminishes after the 4th postpartum day and completely resolves approximately 7 days after delivery. In contrast, pain due to trauma persists at the same or increasing level throughout the nursing episode. So severe pain or pain that extends beyond the first postpartum week is more likely to be due to nipple injury. And that is the most significant differentiating feature that can actually tell that it is just the nipple sensitivity or it's actual trauma. So what is nipple vasospasm? As I mentioned earlier, that the arteriolar vasoconstriction is causing cutaneous vasospasm of the nipple. And it occurs in mothers who have Raynaud's phenomena, an unusual cold sensitivity or nipple trauma. So mother with nipple vasoconstriction typically experience pain, burning, and paresthesia with cold exposure, nursing or nipple trauma. And this pain may radiate into the breast as a sharp or deep aching sensation. The vasoconstriction can be reproduced with the exposure to the nipple to cold or air or compresses. And the good thing is that between the episode, the mother is asymptomatic and nipple will appear most of the time normal. So that's what we just discussed, that typical presentation, pain, burning, paresthesia, that's an altered sensation around the nipple and radiation to the breast.
Can we go back to the previous slide?
Yes.
So there is Raynaud's phenomena would be a common cause, but it would not be exclusively associated with Raynaud's phenomena. Cold sensitivity and nipple trauma can cause that too. So in our population, it should be often associated with the nipple trauma.
Thank you.
Unless anybody else has anything else to add here. Okay, move on.
Can I actually say something? I'm just curious. Would you include nipple compression as trauma, even if there's no damage? Like compression lines and blanching, that's strictly from pressure without trauma?
I think I probably wouldn't.
Okay.
trauma would be some sort of compromise in the integrity of the skin or the tissue.
Right. So do we add compression as another cause instead of calling it trauma?
That is a good question. Maybe something that we should, maybe Rukaya can search it
Yeah.
up.
So we have like
I was just curious how you want us to chart it, really. Yeah. Okay.
So we have a couple of slides coming up that will actually tell that what exactly vasospasm is, like it's blanching or like it's compression or what else. Okay. So with both like primary and secondary Raynaud phenomena. So Raynaud phenomena, as Dr. Salim just mentioned, that it could not be necessarily a part of Raynaud phenomena, but a typical episode is like a sudden onset of like, in Raynaud phenomena, what happens that sudden onset of cold fingers or toes in association with color changes or skin pallor due to constricted blood flow. And what happened that first of all, color becomes changed like white, and then constriction, and then little bit cyanosis of the skin, which indicates like a hypoxia, and then a rewarming phase occur in which it gets blue. So this is like a diagrammatic representation in which typically you can see the left side of the diagram. If you see and look at the nipple, it looks like a blanched white to deep red. So what happens that the first phase, it will be white and blanched, and later on little bit bluish, or then because of the compensating vasodilation, it will look little bit red later on. So it's a classic tricolor change of pallor, cyanosis, and then erythema is actually Raynaud phenomena or cold sensitivity of the nipples.
And it will always be reproducible with the same.
Yes. And the good thing is that in between the vasospasm, nipple will look normal, patient will be completely asymptomatic. This can better be explained by a typical Raynaud phenomena that is actually seen in hands and toes of patient that actually exhibit Raynaud phenomena. You can clearly see that some part of the hand is little bit blanched and yellow, the other one is red. So this is a tricolor change, pallor, cyanosis, and then erythema. That actually signifies that this is vasoconstriction happening. It could be either underlying Raynaud phenomena or just a cold sensitivity. So how do we diagnose it? So basically it's a clinical diagnosis and the history of nipple vasoconstriction occurring during cold exposure and or breastfeeding. So because of the intensity of the pain, a diagnosis of candidiasis of the nipple is often made. However, the trigger of cold exposure for the onset of pain and changes in nipple appearance should differentiate between the two conditions. So most of the time, like a patient is over-treated and get candidial management or antifungal treatment. So that's why it's very important to ask some of the important or significant features, especially because women are not going to tell that we are having vasoconstriction, vasospasm, unless they are asked that, do you have these symptoms? Does your skin get like a color like blanching, yellow, and you feel like there's something happening in your nipple, constriction, you have some kind of altered sensation in your nipple, then there is high chances that you can get the diagnosis. So how do we manage it? So basically lifestyle modification is the important thing in Raynaud's phenomena, and as well as education of the women. So warming the entire body appears to be helpful in reducing nipple vasoconstriction. So affected mothers should breastfeed in warm conditions. Wear warm clothing or use a heating source applied over the bra. Avoidance of vasoconstrictive medication, like some kind, like patient is having like high caffeine intake, nicotine, so lifestyle modification play a major role. We can actually counsel and educate patient regarding those lifestyle simple measures, and this can be corrected. And warming the nipple at the onset of pain, and even laser therapy for Raynaud's may result in less frequent, less severe attacks. However, this therapy needs more study. So what is pharmacological intervention in nipple vasospasm? So we have an option of nifedipine. This is a calcium channel blocker, the class of drug that is most widely used for the treatment of Raynaud syndrome. But we should keep in mind that it can cause peripheral edema, dizziness and flushing, and even headache in some patients because of its vasodilated action. And the dosage is like 30 to 60 milligram daily, either as a single dose of a sustained release product or 10 to 20 milligram 3 times a day as an immediate release product. So,
are there any contraindications for nifedipine?
Contraindications are like kind of those who have like a cardiac congestive cardiac failure, or there should be caution, like caution should be taken, or sometimes patient can have a sensitivity to some kind of medications, yeah, because it has a vasodilatory effect. And but it's regulate blood pressure but not cause significant hypotension.
Okay. So is it safe if for an asymptomatic, suppose we're not sure, we're just trying. Can we just try? Like if somebody does not have this problem, Raynaud phenomena, would it do any, like postural hypotension, is that a risk or no, not at all?
So that's what it has been addressed, that there are some trials, and because of the low level of nifedipine in breast milk, amount ingested by the infant is also small. And
not for baby, mom.
Yeah,
I don't give up.
Yeah, and also for mom, like it's like for adult population, it does not cause significant hypotension unless there is some underlying problem there.
All right.
It's just like a kind of a drug that maintain blood pressure. It does not have a rebound hypotension or something like that.
Okay, good.
Yeah.
That's
So,
good. Calcium channel blocker. Mm-hmm.
So no adverse effects have been reported among infants exposed to nifedipine in breast milk, and the dosage of nifedipine reportedly used to treat the condition is 30 to 60 milligram daily, either as a single dose of a sustained release product or 10 to 20 milligram in divided doses 3 times a day.
Is there, sorry, Rukaya, you might know, the tolerance wise, like, is it like sustained release is better in our case, right?
Yeah.
Or
in terms of like, I did not find any trial that has like compared single dose or immediate release, but it's still, I will look into that and will get back to you.
So now what about the topical? So we were
Yeah. So when I searched literature, I found that there are topical like preparation available with the lidocaine, but that's like used for standard use for chronic anal fissure. So I did not find any particular trial in which local nifedipine has been used for nipple vasospasm.
Can I make a comment just from a practice point? I think sometimes we also see that topical lidocaine cause a cooling sensation that can give shivers and other things that lead to more vasoconstriction. Some parents report that it makes it worse.
Thank you for sharing. Yeah, so that's like in literature, we did not find any like trial that has been done for local nifedipine.
So basically the topical preparation, because I mean, we don't have any pharmacy here to support us. The topical preparation with lidocaine was essentially a different use for the, so topical nifedipine with lidocaine is primarily used for anal fissures. And because there was this combination available already, people started using it for nipple vasospasm. There is also another effect of lidocaine in the compound, that it numbs the skin. Consequently, it also inhibits the natural reflex that is initiated by babies suckling. Now, there is no, we need to find out is whether can there be a nifedipine alone preparation that people have tried before, and is this something that we will be able to incorporate in our practice, because we see a few of these cases.
Thank you, Dr.
Okay, great. Thank you very much.
And so like this is one article I found regarding interventions for treating painful nipples among breastfeeding women in Cochrane. And this was done in a systematic database review in 2014. And it included 4 trials of good methodological quality that involved 656 women in the review. And the 4 trials were included, and all studies included education regarding the position of the infant first, and then there are certain things that have been compared in this, including, so this systematic review evaluated the effectiveness of glycerin gel dressings, breast shells with lanolin, lanolin alone, or all-purpose nipple ointment containing mupirocin, miconazole, and hydrocortisone that we usually tell apno cream. So this is not typically for vasospasm, but this article has actually tested the role of these medications or measures in terms of controlling nipple pain. So the review concluded that none of these interventions were clearly effective in alleviating nipple pain in latching women. And the nipple pain decreased significantly by 7 to 10 days postpartum, regardless of the intervention. So most of the time in early postpartum period, pain usually subsides by its own without having any intervention. Still, despite this, lanolin is frequently recommended by healthcare professionals. A meta-analysis or even Cochrane database review concluded that application of nothing or breast milk may be superior to lanolin, but good studies are still lacking. So make education a continuing, never-ending process. We all are learner and we learn every day new things.
Right.
And this is just a effect of the single irradiation. So what is coming up in future? So there are some trials that are happening in terms of laser therapy, low-level laser therapy on nipple pain in breastfeeding women. So this might be the future of the nipple pain. So I will conclude the session that with some important points that normal sensitivity versus nipple pain due to trauma should be distinguished. Mother must be questioned specifically about the symptoms of Raynaud's phenomena. By recognizing Raynaud's phenomena early in the course of breastfeeding, pediatrician will be able to treat breastfeeding mothers appropriately, and this will actually avoid unnecessarily treating mother for candidial mastitis. So we have used some of the resources that are like evidence-based. So this presentation was like according to the literature search regarding the topic. Thank you everyone for listening.